would like to invite Dr. Shaleen Agarwal, our lead commentator.
So Dr. Shraddha has almost covered everything. Most of the good papers have been presented here, and she has already reviewed the literature, but I have also reviewed the same papers. So the message remains more or less the same, but I would like to make a few points. So one is, what is the like timing of reoperation? So since this is the question for discussion, so first we have to define what is an ideal time for reoperation. And before that, we need to know, does timing of re-resection impact outcome in terms of survival? Then how to define an ideal timing? So what I tried to put together from the literature is that ideal timing is one that reduces the technical complexity of re-resection by allowing the inflammatory process to subside. At the same time, allows it's long enough for and allows the tumor biology to manifest, and then of course provides the best long-term outcomes. That is how you define an ideal timing of reoperation. And then what is that ideal time? So these are the three questions that came to my mind as sub-questions for this lead question. And so first of all is timing of reoperation. Does it matter? I would say after reviewing all the literature, this timing remains debatable. Dr. Shraddha has already said so. So there are two schools of thought. One just discounts that. It says timing does not impact survival, while there are several studies to suggest that yes, timing is important. But again, in these studies, there is no consensus on ideal time of re-resection, as has already been discussed. So I would go back to Shraddha, your center's publication, earlier publications, which showed that timing doesn't matter. There are two papers. You have published a third recently in which you did that propensity score, but the earlier papers clearly showed that its primary determinant was the disease stage and lymph node status, that is the tumor biology, not the timing. So they said that they were in the first paper in 2008, at the time of when Dr. Parul was there, they resected patient even who presenting 11 months after their first surgery, and they did well, could show long-term survival. So the gist of these two papers are that timing does not matter. Well, then the other school of thought is that timing does impact survival. And yes, this paper again that showed that even the operability is not different when you consider the time periods of 1 month, 1 to 2 to 3 months, and then more than 4 months. So the operability repair rates remain the same. That is, you didn't have a lot of fallout because of patient presenting with advanced disease or metastasis, nor does the timing impacted the outcome. Now coming to the other school of thought, which says that yes, timing does matter. But here again the controversy. So whether to resect early, that is within 2 weeks, this is the Chinese paper you quoted. So there are two Chinese papers, one says that within 2 weeks is the best time period, other says if you operate within the first month, it gives the best results compared to patients who are operated at longer intervals. You have shown, I'm not going into the details in terms of difference in survival advantage, but there was a significant survival advantage if you operate early. This is what the Chinese go to say. But then you have these widely quoted papers, the Ethun's paper, which is a multi-center study from US published in JAMA. But actually, if you go into this paper, there are 10 centers, collected data over 14 years, only 207 patients. So there's wide variability. And they have clearly gone on to show that if you operate between 4 to 8 weeks, you get the best outcomes, that is 40 months versus 20 months. But in the same issue of JAMA, this, the editorial board has criticized this paper by saying that although they have shown that there was no difference in the stage of the disease, but in terms of actual numbers, the patients who were operated late had higher T3 patients, though the difference was not statistically different. And then each group, the number of patients were very small to make any significant comment on statistical outcomes on the basis of statistical analysis. So there are criticisms for this paper, although this is widely quoted and published in a reputed journal, but it said that 4 to 2 weeks is the best time. But again, if you go to the SGPGI paper, they say 4 to 12 weeks. So first we have no consensus on what is the intermediate period. First was Chinese said operate within 2 weeks, that is the best. Another Chinese paper says operate within the first month. Then we come to this more widely quoted papers which say within 4 to 8 weeks or 4 to 12 weeks. And then there is a Brazilian consensus and there is another consensus. Due to, in the interest of time, I have not put all the papers, but 4 to 8 weeks have been recommended. Again, these are some consensus coming from different part of the world, but still there is lot of confusion. The reasoning which has been given is, we have already talked about it, that it allows time for the inflammation to subside, gives you a better chances of staging, there is reduced technical complexity, and then waiting beyond this may lead to dissemination, but the data doesn't support that. So, and then there is paper which says that late resection is best, that is late means after 3 months, because it allows the tumor biology and occult disease to manifest, and therefore it avoids unnecessary negative laparotomies, because many a times even at staging laparoscopy you miss a disease and you land up with negative laparotomies. And 4 to 8 weeks, although it's widely quoted, may not be enough for inflammation to subside, which is often quoted as the reason for doing the surgery within 4 to 8 weeks, because the inflammation subsided, but that may not be true in all the cases. So in nutshell, I can say that one, there is no consensus whether timing impacts outcome or does not. Second, even if we consider for once that yes, it impacts, then what is the ideal time? There is no consensus on that. Different papers from different parts of the world have given different time intervals. Less than 1 month, 1 to 2 months, 1 to 3 months, more than 3 months, all showing good outcomes, all showing good operability rates. So there is no consensus. And when there is no consensus, that means that is a gray zone, and probably the previous papers saying that timing may not be the most important thing, that stands true. So my final comments are that re-resection improves survival, we all know, and that stages. And as we said that even in T1A, where you don't have clear-cut histopathology or about the surgical details, you should go for re-resection. So we should go for re-resection. But tumor biology, as with almost all cancers, is the most important, which includes the T-stage differentiation, microvascular invasion, nodal metastasis, residual disease at the time of resection, or detect residual disease. And therefore, R0 status at re-resection, that justifies re-resection, but you have to achieve R0 status. But again, achieving R0 status is not as important as the presence of residual disease. And probably that correlates with the advanced stage of the tumor. The higher the tumor stage, you are more likely to have residual disease. Timing of re-resection is probably not as important, so we should not harp a lot on this issue. International, not guidelines, but consensus statements which are based on these papers have suggested 4 to 8 weeks for ideal time of reoperation, but individual studies, as we have talked about, have supported all time frames. So re-resection should not be denied to a patient who is presenting beyond this time limit of 8 to 12 interval or coming early. We may ask, but if sometimes you have to look at the ground reality, and if the patient is very anxious, we may, after doing that staging, we can go for early resection, we can stick to this. So it all depends at what time the patient is presenting to you, rather than sticking to a fixed time frame. That may not serve the patient well. So more important is the role of thorough preoperative staging, though you may fail even after that. So review of previous histology, talking to the surgeon, getting the notes, PET CT, CE-MRI in selected cases, and then staging laparoscopy cannot be overemphasized. So more than the timing, it is the nature of the disease, presence of residual disease, and then whatever time it is, stage the patient thoroughly before you go for re-resection. Don't stick to fixed time intervals. That is what I got from all the literature. Thank you.
Thank you, Dr. Shaleen. Now we have online comments from Professor Orlando Jorge from Brazil. It's recorded, or? We have
नहीं है, मैं पहले चेक कर लूँ। नहीं सर,
उसमें से आपने कर लिया था ना कॉपी?
सब पूरा करा है।
I think Ram ji carried.
Right. So, as we have heard both the speakers, still there is no consensus on what is timing, what is early, what is intermediate, what is late. Still we don't have even that consensus. So timing of surgery we cannot make out as such right now. But I have some questions from the house. Whether location of tumor in the neck surgery will change your timing of surgery, reoperation?
That is very important.
Whether it's a fundus or at the neck of the gallbladder?
No, I don't think I would wait for just because the site is different. You can say that the prognosis may change. Tumor on the peritoneal side penetrating the serosa has a higher likelihood of disseminating peritoneal dissemination early rather than those on the liver side. But its impact on my timing of operation will not be there. It it may impact the outcome. I may do more staging and more investigation if it's a tumor which is likely to have on the peritoneal side, but it won't impact my timing.
Sir, what about fundus and neck lesions, sir? One of the reasons is at the neck of the gallbladder.
I don't think it will impact the timing. As sir rightly said, it may impact our preoperative or pre-staging workup, whether you want to look at the patterns of spread and ultimately decide which tumors are going to behave adversely. But I don't think it has an impact on the timing of surgery.
So, what is your selection? How do you select? You
No, I don't think again it makes impact on timing of surgery. You again it may you on the other hand may want to give neoadjuvant therapy.
Dr. Shraddha, what do you recommend? Early at the immediate after surgery or after 4-week interval, or what do you recommend?
So I'll tell you, based on our experience, our index time of presentation of most of our patients is 10 weeks. So at 4 weeks is a reasonable time to restage the patient, and if the patient at that point of time is non-metastatic, then he or she definitely warrants a research.
But patient come early, suppose after 2 weeks, then what you will do? Will you operate at a time, or you will wait for 4 weeks or 10
I
weeks?
think it's subjected to staging the patient, and if after an informed consent and informed decision making with the patient that this is what it is at this point of time, you don't have any residual disease. So it's fairly warranted to subject the patient. We don't have great evidence to suggest one or the other. So as long as the patient on restaging is non-metastatic, I don't think you can deny a patient a resurgery at that point of time.
Will you like to wait? Will you like to wait for that time inflammation to settle down?
Ideally, yes. So 4 weeks is the cutoff which we've used in our practice for now.
Dr. Shaleen,
Again, so just a small subset of patients, because if you, as you said with the previous question, that if the margin is positive or it's a bad biology, so if you have a trial going on and you want to attempt or try new adjuvant, then the timing may get delayed. But otherwise, I won't like to wait. Whenever the patient presents through a good staging, and go for reoperation, because as literature shows, there is no ideal time. Even the Chinese are saying operate as early as possible, but most of the patients in real life scenario, until unless it is your own operated patient, will present towards the end of 1 month, that is 3 to 4 weeks. So even if you are not choosing, most of your patients, if you look at your data, would be get operated automatically within that time.
so my question is, if they present early at 2 weeks in the house, how many of you will operate in as early as possible?
I will go for operation early. So as I said in my talk, don't stick to fixed time frames.
Just a small question. Are we doing the same surgery? All the data, what we are seeing, Chinese data, SGPG? No. Okay. So that is the foremost important. When we start comparing the results of early surgery and late surgery, we have to admit that we are not doing the same surgery. Okay, that is one. Probably why the difference is coming, because in centers who does aggressive surgery, I think majority of them go early. Probable reason I assume is the window period of spreading and the benefit you are getting by little bit extending your surgical margin in terms of lymphadenectomy or liver, those subgroup may get benefit. Other way, whatever you do, whichever time you present, you do a small wedge resection or liver and you do a standard lymphadenectomy, definitely it is not going to change your outcome.
I totally agree.
So this
with you
is
that the extent of
what I am trying to
surgery
tell is,
we'll discuss that.
Yeah.
But extent is not going to make any difference. It's been shown best. Maybe by doing extensive lymphadenectomy, you may have a stage migration. But in terms of your surgery making an impact on the outcomes, I don't think the two procedures.
no, I am
are
just talking
different.
about timing of surgery.
Yeah.
Timing of surgery.
And coming to that, I think in this era of lap polycystectomies, actually there's not so much of inflammation. We have seen repeatedly, if you have operated early, there's no harm in operating early.
So that's the question I wanted to ask the House. We seem to have this equipoise between inflammation to subside, and is there so much inflammation after a simple cholecystectomy?
Yes.
What have all of you
I've
felt?
not seen that much of
Because
inflammation.
This is what actually I want to ask. Actually,
I've done only.
we
I
can have
did in the
cholecystectomy
first-
for empyema gallbladder, or we can have cholecystectomy for simple gallbladder. So will it?
These are, each individual case.
No,
will
not
be
the
different.
inflamed, not the bile leak ones.
Yeah.
Yes, sir. Not the
Apart
bile
from
ones, but
these
inflamed.
two, has
In
anybody
any
had
case, a
problems
patient
of
empyema with
inflammation?
incidental CAGB or bile spill will
Even
have
for
an
1 week,
inferior
you've
outcome.
had?
Whether you wait or don't wait, they will have inferior outcome. So better to
put them into trial of neoadjuvant. See, neoadjuvant is not a standard procedure for CAGB till date. There are a lot of papers coming up, but maybe it becomes standard. So start a trial and then put them on neoadjuvant rather than wait for just wait. Pure waiting is not going to help.
So because staging can take in hardly 2 to 3 days nowadays.
I have two philosophical questions. If you see an early primary gallbladder cancer, suppose you have by chance detected it, looks early, would you wait? Then why wait for an early incidental gallbladder cancer? Second question is, the Tata group said T1B PET negative, when they reoperated, they found no residual disease. So which means reoperation was not required. On the other hand, you say if there is residual disease, outcome is poor. Reoperation doesn't help. So how do we solve these philosophical issues? And my question to those who recommend waiting for 4 weeks, 8 weeks, and I think it is in SCPGI paper, it is 4 to 12 weeks, the intermediate group. If you are diagnosing, suppose a patient comes to me at 7 days with a histopathology report of incidental gallbladder cancer, whether I do a PET scan today or suppose I do a PET scan as we all agreed and it shows no residual disease, do I tell the patient go back after 12 weeks, then I will reoperate? Will any patient accept it? So that is different. If a patient is coming late, you have no choice. That is not the discussion. Discussion is when the patient has come to you on day 7.
Yes, so we should operate early. Don't wait for
But the problem is these two papers are giving rise to guidelines or recommendations saying that wait, which I think is wrong.
So
So if we look at reoperation from non-malignancy, normally in the first 7 days, we don't have vascular inflammation. We don't, I mean, it is all simple adhesions. So with that, at least the worst time is around 2 weeks or so. So I don't know where that cutoff came. If it's 2 weeks, then we wait for another 2 weeks or so till it settles, the vascular bit settles.
So SGBJ paper.
So the caveat to all the papers has been they have chosen timelines based on the referral pattern to their own institution. So if obviously, as sir said, that if you have a patient who's going to refer to you after 4 weeks and that is your median time of presentation, I mean naturally you are not going to have patients refer to you at 2 weeks and the experience of doing an early surgery or even proposing anything gets nullified.
So you might find on the meta-analysis it's their median time is what they're recommending, which is ridiculous. I think we should probably meta-analyze that.
And since we have so many time intervals, I think timing doesn't impact at all. I would say that we should operate when it's covered.
We are talking of referral. So you have done a colonoscopy. The incidental report comes after 48 hours, 72 hours.
Do that as quickly as possible.
So you won't wait, right? So so then the timing is irrespective of referral or whatever. So perhaps the conclusion would be that based on the disease factors and the T stage and all other things which we said, if resurgery is warranted, should be done at the time of presentation, period.
And if we do at this point in time, after say
Which you would agree with that?
Practically, there won't be much inflammation. Okay, we are unnecessarily talking about inflammation in the hilum. There won't be practically nothing. It never pose any challenge. That's what my experience. And I don't discharge a patient who is diagnosed with carcinoma gallbladder, incidental gallbladder, and go home and come back. I feel it is beyond my limit.
I think this confusion arose from the MSKCC paper in which they said the reoperation was difficult and increases the chances of bile duct resection was higher because lot of inflammation was there. They were not able to decide whether it was inflammatory change or it is malignancy. And that is why the timing of dilemma came up. But that is why if you do very early, sometimes additions are so that you feel that you have not done the ideal lymph nodal dissection that you would have liked. So many times because of dense inflammation, sometimes problems are there. But in our analysis, we have also realized we have categorized within less than 4 weeks, 4 to 8 weeks, and we didn't find any difference in survival or resectability rate. Slightly blood loss was slightly higher in the early group, maybe because of a result, but not much difference. That was also noticed.
Before deciding the timing, will you not ask the surgeon, previous surgeon, what was the condition of Kellert's that time? What was the condition of gallbladder that time? Because it depends on that. If the condition, you must talk to the surgeon and ask that what is the condition of the gallbladder. If the condition of the gallbladder was bad at that time, I think you must wait in. So timing depends on the type of gallbladder which was there at the first operation.
I think it is very difficult to get all the information from surgeon, but most of the time once you do a CT scan, many times you find there is a lot of inflammation is there and that area is not good time to invest, go ahead with surgery. That many times you will find lot of collection is there, sometimes bowel loops are adherent on those areas, many times you will find on CT scan. But how to not operate these patients, that is very difficult. So we started a trial around 10 years back for giving neoadjuvant in these incidental gallbladder cancer in which these are T2 or T2 or more, but we are not able to recruit more than 10 patients because the patient will go at multiple places and there is no guidelines to give neoadjuvant chemotherapy, there is no time to restop the trial. So we operate at present and we didn't find any difference, statistical difference in survival or any resectability rate.
Sir, if I am interpreting it correct, if the patient comes to you after a week, you will do a PET scan first. And PET scan shows a nodal disease, you will send him for a neoadjuvant. If the patient does not show any disease, this is the only patient whom you will do a extended chole now.
If the PET shows nothing,
then do a, so if you find PET scan normal, that is the only indication for extended chole.
It means the first investigation was done as this PET disease.
But the answer to your question is that if the PET is negative, so say you go for release.
What is incidental? That means it is not
Later staging. Surgery is the final port of the
No. So the only reason.
only gallbladders which will be bad are the ones which are, since this is IGBC, are the ones where the gallbladder cancer is obstructing the. So, I mean, the question somebody asked, will the location make a difference? Possibly yes. Because if that is causing the inflammation, the inflammation is probably better work.
I agree with say that I totally agree. Inflammation is overrated.
Sir, I have one query.
To answer Dr. Shaleen's question, that PET scan, if it is negative,
Sir, I have one
the
query.
only indication to do an extended chole is to have a histopathology of a nodes that they also support your diagnosis that he will have a better.